do something like an ACR, but it's something which everyone can use. Can you guys see my slide?
Yes.
Okay, so these are my disclosures. The one which is important here is I believe in this technology, so I've invested in the company. What is the aim? This is the aim. So if you look at this, the patient number one, which is in the middle, got a large retracted rotator cuff tear. As Nick was saying, this is almost a 40 to 50% re-rupture rate. And this is the result we get in a patient like this at follow-up MRIs at 6 months. You can see the tendon's really thick. The enthesis is formed. It's almost like a roots of a tree, which are embedded within the humeral head. And this is on the patient number two. On the flip side is another patient with a smaller tear, but then the quality of the tendon and the enthesis, which is formed here, is very, very thick and robust. We know that as we have more fatty infiltration, the re-rupture rate for cuff tears increases dramatically. So there's a lot of factors in rotator cuff repair. And in my journey over the last 10 years, we've done a lot of work looking at preoperative assessment. Of course, you have to choose the right patient. Surgical technique is really important. And then we talk about augmentation. So there's a case like this. We have a 54-year-old guy. He's a farmer. He's a heavy manual worker. What do we do for him? Do we SCR this? Do we do a tendon transfer? Do we do a balloon? Do we do a patch? The jury is really out there. A similar guy, one of my patients, 45-year-old fireman, you look at the Y view and it looks like, oh, maybe this is not a repairable tendon, or maybe we need to do an SCR or, something. So one of the big things which we've looked at is we've looked at looking at the Goutillier grade for these patients much more medial. What we believe is that if you look at the rotator cuff healing at the Y view, we're actually looking at the wrong section of the scan because the rotator cuff has retracted. Whereas if you go much more medial, you see while the cut sequence is here, the muscle quality actually looks much better because this is a large retracted tear. So what we believe with this is that the classification which we've developed is it's a medial scapular body classification where you actually need to look at the muscle fatty infiltration much more medially. Then the question comes is how do we repair these massive rotator cuff tears? And we've developed a technique here, which, one of my friends in Japan started off, and then I've pushed the boundaries for this. And this is called a muscle slide technique. It's no different to doing a JOEI approach for a scapular fracture, where we peel off the supra and infraspinatus and repair the fracture and just let the muscles heal back. The thing here is this is done all arthroscopically. So we basically detach the supra and infra from the bone, leave the superficial fibers intact. And this gives us a 5 centimeter excursion of the tendon so that you don't actually need a patch or a graft to augment this. So this is the paper which we published a while ago. Now we've gone up to 101 shoulders, and everybody's had an MRI done. As you can see here, 96.8% have had MRIs done, and we've got a mean follow-up of more than a year using this technique. And I have been able to achieve a 92% healing rate. This is independent of Tetris. I'm just trying to give you a preamble. So I've had 8 re-tears and almost these 100 patients now. And this is one of the re-tears which I've had, which needed something to be done. So in my hands, if we had patients with large to massive rotator cuff tears, the smaller ones were not a big problem in my practice. But in these large to massive rotator cuff tears, which are retracted past the glenoid rim, which had spurred a whole different bunch of operations from an SCR, et cetera, et cetera. I strongly believed if you can repair these tendons back normally, that gives the patient the best outcome. So this involves a whole bunch of releases, which are periarticular releases to release the tendon, ensure that we can achieve a tension-free excursion of the muscle tendon complex. And as we all know, unless you have a tension-free repair, the tendon's going to fail. One of the key things in this is to dissect the neurovascular pedicle, which is the suprascapular nerve. So I like akin to any plastic surgical procedure where we do flaps, we rotate the muscle tendon complex on its pedicle. So one of the cornerstones of this procedure is to dissect the suprascapular nerve and artery so that the muscle and the tendon complex is moving on this pedicle. And also, we know that the suprascapular nerve is the carpal tunnel of the shoulder, and enlarged retracted cuff tears. This retracts much more medially and causes a fair bit of pain. So in this case, as you can see here, the suprascapular nerve is released. It's in healthy fatty tissue. The nerve is usually always a little bit congested, and it provides really good pain relief to the patient post-operatively. But this is one of the cornerstones of massive cuff repairs from a surgical technique point of view. Then arthroscopically, we just keep dissecting this more and more medially and keep releasing the supra and infraspinatus medially all the way till the medial scapular border. And this is just allowing for excursion of this muscle tendon complex without devascularizing the muscle or the tendon complex, so that we can get the whole muscle tendon complex to cover the footprint completely. So when I finished this part of the operation, I was still not happy with the amount of excursion I got with this. So then what we do is we make a small mini open approach and we split the fibers of the triceps horizontally. So you're not destroying the triceps at all. And you use a Cobb's elevator and you're basically stripping the muscle supraspinatus and infraspinatus off the supraspinous fossa and off the infraspinous fossa, so that you're releasing the attachments of the muscle medially. We don't go any far more lateral to where the suprascapular nerve pedicle is. And then this is the excursion you get of this rotated cuff, which an hour ago was deemed to be irreparable. Following this, as Nick has shown, you just pass your standard sutures. I do a lasso loop technique because I was taught by Laurent Lafosse. I don't do, suture bridge kind of configurations. I believe in tying knots. So we get this deep delaminated layer, which is the key for the rotator cuff enthesis to heal as well, because this has the strong collagen and the tendinous fibers which require to heal onto the footprint so that we can get a really robust rotator cuff repair. So this carries on, and we were able to get a successful double row repair achieved for this massive irreparable tear. So this is how my journey started. So when we pull the deep laminated layer down, we get a watertight closure, which is really important. And then, a lateral row repair is performed. So this is what it looks like for something which was deemed irreparable 90 minutes ago. I'm not going to show the open dissection. And so the results of these 100 patients was that we were able to achieve really good outcomes. You can see the post-op external rotation, lateral elevation, and forward flexion was incredible. For me, I was not able to get symmetrical post-op external rotation with tendon transfers. If we look at the patients with pseudoparalysis as well, we were able to revert pseudoparalysis in these patients, which makes sense because if you can repair the cuff, the pseudoparalysis should get reverted. So it was a very powerful technique in young patients. The most important thing was we were able to get strength back. Post-operatively, we are able to get over 90% strength back of the supra and infraspinatus, which no other augmentation technique or rotator cuff repair technique per se can achieve. And irrespective of the gouttelier grade, when we looked at the strength of supra and infraspinatus, they still did really, really well. So we've looked at preoperative assessment, we've looked at the surgical technique, and in my hands, I'd maxed all of this out, and still I was getting failures. And still at the end of the operation, I wasn't happy. And I knew that the biology was missing from this whole, a la carte approach I had for these tendons. And what else was needed? And that's when Tetris came around. So for me, this was really interesting technology. I will not show the Tetris video because Nick's just shown that. But I, use the implant. It doesn't even add more than 5 minutes to the case. You can use it in osteoporotic bone to supplant the anchors, or just put it in between in the footprint. So what we tried to do is we tried to look at the 31 patients now in which we have used the demineralized bone fiber group and compare this to a group of patients who had a muscle advancement procedure with smaller cuff tears as well. So muscle advancement and smaller cuff tear, so that we could have a really heterogeneous cohort and look at if if actually the biological implant and the biological augmentation was making a difference. So for the purpose of this study, I started using tetras with really large tears, which were essentially all of supraspinatus and infraspinatus tears. They had pate 2 to 3 retraction with low grade of fatty infiltration. So these were the big muscle slide cohorts to start with. And our results were very encouraging. So without the augmentation, you can see the patient on the right. The cuff is still healed, but the quality of the tendon looks a bit sus. The patient's functionally doing quite well and the strength's good, but just that MRI is not as happy looking as the one on the left. You can see with the Tetris implant, much nicer, thicker enthesis. Footprint coverage is excellent, and the head's really nicely centered as well. So we did see with this that the mean tendon thickness has grown by around 0.5%, 4 mils or 5 mils, which is significant at that point. If we look at the range of motion and forward flexion, the Tetris patients are doing as well as the other, if not better. These are still 6-month data, so I think in time this will show things better. But we had a big hunch that the Tetris patients are outperforming my non-augmented patients at every time point from 6 months to 12 months and even at 3 months, which we are collecting data now. The strength measure is still equivocal right now because my rehab is very conservative for rotator cuff repair for strength in the first 6 months. So the strength for the supra and infra is equivocal right now. But since I've been using this in the last 6 months and I've seen this data, I've actually started an accelerated rehab protocol now in patients who've had the implant. So one of the things which we wanted to study was, does this actually, the thicker, more robust tendon mean earlier recovery, mean faster rehab, mean earlier return to work? And our provisional data does show that the pain relief is better. The ASCS scores at 6 months with the Tetris group, which is the blue, is equivalent to 12 months with the non-augmentation group. So we compared the 6 to 12-month data between the augmentation and the non-augmentation group. If you look at the constant score as well, which is a good measure of functional outcome and strength, we're achieving strength at 6 months, which I was achieving at 12 months. So I've actually started counseling my patients now that they're going to get back their full strength and function at 6 months, which they were getting at 12 months, which in everybody's game is a game changer. The UCLA is better. And even as I mentioned, the strength doesn't show that data right now, and that's probably because of our rehab protocol. So to summarize, despite using muscle slide and advancement for these massive rotator cuff tears, this is a very viable technique which eliminates the need for an SCR or tendon transfers in the vast majority of patients. And this, in conjunction with demineralized bone fiber implant, leads to an excellent enthesis formation. And the results at the 6-month mark are very, very promising. We've submitted the original results for publication, which is going through a peer review process, and we should hear, any week. But we do need at least a 1-year follow-up on all the patients in the future. But the early results are extremely promising. Thank you all.
Right.